Hey everyone, this is Tom Salemi of DeviceTalks. Welcome back to the DeviceTalks Weekly podcast. Got an old school format for you today. We'll have the Newmakers with Chris Newmarker, editor of MassDevice. He and I will review the top news of the past 2 weeks because we didn't have a Newsmakers for you last week. And then we'll roll into our Keynote conversation, which is longer than usual. But we covered a lot of interesting ground following the career and journey of Vishwa Srivastava, Dr. Vishwa Srivastava, the now president and COO of SS Innovations International, which of course is the real surgical robotics up and comer, but powerhouse. SS has developed the Mantra 3 series, which is a rival to Da Vinci and to Intuitive. And as we'll talk about in the podcast, Vish, who is probably the second best known face of SSI, behind his dad, who was the founder of the company, he will talk about his view for surgical robotics and how he doesn't see Intuitive or anyone else as a competitor. He doesn't mean that in a arrogant way, but rather he sees this space growing so broadly that there'll be plenty of business for everyone. And SSI really is blazing a trail into new markets and with new technologies. We'll talk about telesurgery, which is something that SSI has been doing a great deal of, but also just the emerging uses and needs for a surgical robotic system like Mantra 3. So enjoyed my conversation with Vish a great deal, and I hope you do as well. I'm sure you will as well. But before we begin this episode, I want to invite you to take part in a Device Talks Tuesday that's coming up that's related to our topic of the day. It's a surgical robotics discussion called Driving Precision in Robotic Surgery, the Impact of Catheter Materials, brought to you by Spectrum Plastics Group, which is a DuPont business. We've worked with both Spectrum and DuPont in the past. Happy to have them combined and part of Device Talks Tuesdays. And we've got a great conversation that you can find at devicetalks.com. We will have David Kramer, who's the engineering director of Healthcare DuPont. Also, Steve Maxon, who's VP of Growth for Chomfer, which is another DuPont company. And Joe Bukowski, who is the staff mechanical engineer at Intuitive Surgical. He'll be on the panel as well. So I hope you'll go to devicetalks.com and register for this Device Talks Tuesday's discussion. I'll be the moderator. It happens Tuesday, October 28th at 4 p.m. Eastern. It's free. You can ask your questions and get them answered right away. You can also watch the presentation on demand when it's most convenient for you. You can ask your questions then as well. You won't get your immediate answers, but it will go over to Spectrum, and they'll be able to address those questions. So I look forward to talking with you on Tuesday at 4 p.m. And without any further delay, let us get this episode started. Let's go. All right, you ready for this?
Ready.
Chris Newmarker, how are you, sir?
Doing well, Tom. Doing well.
Excellent. Good to hear. So we're, a week removed from Device Talks West. It was a week ago. Day 2 was a week ago on Thursday. We're recording this on Thursday. Hard to believe.
Yeah.
So,
time flies by, man.
It really does. It really does. Thanks to everyone who came out. Great crowd, great speakers, lots of great feedback from folks. And it's over, and it's done, and I've spent this entire week a shell of a man.
I bet.
Post-conference time is hard. Yeah, all the adrenaline just rushes from your body, leaving nothing except vapor to hold you up. So
I was bummed I couldn't make it, but
I know. We
missed
you.
Yeah, I had some stuff at home, but it's all good now.
We missed you. I did do. I like to, at least whether it needs it or not, after I'm done with conferences, I like to clean my office. Like that week after. So I got the good vacuuming, wiped everything down, and I probably do it more than once a year, but something very therapeutic about cleaning it after you're done with a big project like that.
You feel
Just kinda-
super organized. That's actually at top of my list this week. I'm talking to you from a Thursday, and I've got the dining room in the background because we store a lot of art supplies in my office and the cupboards.
No!
And I
No
know the
art
kids.
supplies. Don't call them art. First of all, let's not call them art supplies.
I mean,
They're
it's paint.
weapons.
Yeah, it's weapons. Yeah,
Weapons and tools of destruction.
Paint and brushes and slime and.
That's your office, man.
I know. Gotta set some more rules here.
Where all the creative MassDevice magic happens. You need to keep that free of kid karma. It needs to be Chris karma.
My kids want the creativity in there, but that's gotta. Dad's gotta have some more boundaries. But I gotta be like, come on, because I will be cleaning the office this weekend. That's actually a big thing to do. Like, look at all like sorting through the my children's art and deciding what's good for mementos and what can just go to the recycling bin. But
take a picture of it on the phone and then send it on its way.
That's true. I mean, am I ever really going to go through those bins?
You are not. No, you're not.
They're just all going to pile up.
Your kids are not going to be artists either. I'm sorry. They just won't be.
It could happen.
Parents are great.
Who knows? I mean,
that's right. No, you're right.
I mean, that could be my retirement. I mean,
exactly. That could be. They could all be the three of them. They could be.
That collection is going to fund my Caribbean island.
The unbridled optimism of parents with young children.
That's right.
Could happen.
Anyway. World of possibilities, man.
Let us deal with the now and the present, Chris Newmarker.
Here we are, the here and now.
Week plus of news. You've got because we didn't do newsmakers last week. We've got some highlights of the past 2 weeks. Big stuff, too.
And let me tell you, there's so much news the last 2 weeks. I mean, everything I think on this list could have theoretically led a Newmarker's Newsmakers on a usual week, but instead it all just happened in the last 2 weeks. And let's just just to kick it off, senior editor Sean Hooley. This isn't as much news, but it's just a really article I'd really recommend for people on MassDevice right now. Sean has an article, How Olympus Views Different Swan EndoSurgical Surgical Robotics Play. It's an interview that Sean did with Bob White, the former longtime Medtronic executive.
I was there. I was in the room when
you
it
were
happened.
there. That's right. He said he was
right
with you
table.
at AdvaMed. Yeah,
that's right.
It looks like it was quite the interview. Like some really good insights there.
Yeah. Sean did a great job, and Bob White's one of the nicest people in MedTech, so it went super well. Yeah, and I mean, he talked a bit about Swan and sort of how Olympus, what Olympus contributes to that partnership, which of course includes some private equity, and they're going to be developing an endosurgical robot. So definitely a creative way to put things together. And Bob White did say that he sees this model as a way that MedTech could go forward to take on big capital projects like robotics instead of internally developed plans like other companies have going.
Doing full-blown acquisitions. I liked the one quote here in Sean's article that really stuck out with me was he said, if you're going to innovate, you're going to innovate quickly. And I mean, it really seems like doing that that kind of like co-founding a separate company, for surgical robotics play. I mean, that was his strategy to get this done quickly and get Olympus innovating a lot more. So I mean, that's really exciting.
Yep. And of course, Bob White, longtime Medtronic executive. So interesting juxtaposition there.
Yeah. Really interested to see where it goes next. So
absolutely.
Next up on the list, like number 4, and this is another good one from Sean, is Boston Scientific. They're making another acquisition, like $533 million for Nalu Medical.
Yeah. So the timing of this was interesting. We, of course, had Ray Cohen, who was, I don't know if he was chairman or on the board of Nalu, but we spoke to him on Thursday morning, and this news came out on Friday morning. About the sale of Nalu Medical. So he's got a string of successful M&A going on. He seems to have the Midas touch, and especially with Boston Scientific, they like what he's working on. So Ray Cohen will continue to be a very busy board director. In fact, after the talk I won't say who, but after my keynote talk with Ray, another one of our speakers who's CEO of a startup came up and said, I need him as an advisor. Where is he?
Yeah.
And I'm like, you
I mean,
went
it
that
says
way.
he's board chair of Nalu, and I mean, just like all the different companies he's involved with at this point, and
Sonovi, of course, Axonics, of course. Now he's the chair of Resonant Link, which was an interesting battery company, which is kind of a cool move, and going to be interesting to see how he, not he specifically, but what he sees in that kind of company, because it's different than Nalu and different than Sonovi, different than Axonics, being a battery company. So they must have something super going on. I think they do, but Ray Cohen would know better.
You know, in Nalu, just to let everybody know, it's a spinal cord stimulation and peripheral nerve stimulation technology to treat chronic neuropathic pain. So that whole like spinal cord stimulation space has been just really interesting in recent years, and it looks like Boston Scientific was like, let's get more involved in it.
Yeah, but this is slightly different in that it's peripheral nerve, right? So this is actually at the target of where the pain is, like on the arm and on the leg?
Spinal cord stimulation and peripheral nerve stimulation. So it's got there's some options here going on. And it's like it's a miniaturized implantable pulse generator. So just really, really cool tech here. So
yeah, no, we had Axonics featured prominently. Not only Ray Cohen was at DeviceTalks West, but we had Kat Jennings and Kristen LaRocca of Boston Scientific talk about the sort of the process of bringing in acquired companies like Axonics and like Silk Road. So it was an interesting sort of. I got to talk with the chairman who sold Axonics, the CEO who sold Axonics, and the company that acquired, and sort of the integration part. So it was a very, very cool complementary conversations.
I have to say, you and Kayleen have just done like I mean, we help you out. I mean, the whole editorial team, we give you guys a lot of advice, but I mean, you've just done a fantastic job just lining up just like so many like top executives. And I mean, it's just like our DeviceTalks shows at this point are just like where it's at to like, I mean, people are missing out if they don't get to these shows and, and really network with everyone there. And just to go along with that, number 3 on the list, I mean, gosh, you pretty much opened up DeviceTalks West with, J&J MedTech EVP and worldwide chair Tim Schmid. And it just happened to be going on when J&J announced that they're going to be separating DePuy Synthes from the rest of the company. So he actually was discussing, kind of where he's seeing what he's seeing with portfolio realignment, over there to, advance the future.
Yeah, the news of this, opposite of Ray Cohen's news with Nalu. This happened the day before. This happened on Tuesday. So J&J reached out and was kind of like, we assume you're going to want to ask about this. And I said yes. So it was a great conversation with Tim Schmid. We obviously let off with his story, but then he got quickly into this. And it's consistent with what you've been reporting on at other MedTechs. This is just MedTech companies really focusing on their high growth business and divesting those that aren't growing as quickly and maybe would benefit from a singular focus. So DePuy Synthes, I think he said, was the 13th biggest MedTech in the world as it is, and I think the biggest,
one of the largest
orthopedic companies. So
yeah.
So it's not ain't no little thing.
No, I mean, and it looks like there isn't any word yet on where it's going to be based. Because DePuy has big facilities in a number of states. So I mean, that'll be really interesting for us to follow over. But DePuy and is the largest ortho business in the world.
Yeah.
Actually, I mean, so but yes, they've got like big facilities in Massachusetts, Pennsylvania, Indiana. So, we'll see. It'll be interesting who's going to get the headquarters of this. I assume they're going to keep the DePuy name because it's like so well known in ortho. I'd hope so. And that's going to be that's kind of cool. Like DePuy Synthes is going to be like this independent name out there again. Like that's a big player in the ortho space. I mean, with their large presence in Warsaw, Indiana, I'd probably be really excited around Warsaw and that this is happening.
DePuy Synthes is currently headquartered in Raynham, Massachusetts, but
Okay. Maybe Massachusetts is going to get a headquarters, maybe.
I don't know. Well, you know it. I think I don't know why I think this, but I think Westchester might be the place, but I'm not sure. I don't have any insights on that directly.
I've had Raynham in the past, so
yeah. All right. Well, let's see. A little wager going on. We'll see who gets the HQ.
Massachusetts.
I wouldn't bet against Massachusetts, though, of course.
No. I don't know. One should bet against Massachusetts, but yeah, it's Massachusetts. It's Indiana. Like, well, we shall see. So, but yeah, this is.
Yes, but thank you to Tim Schmidt for being available and for opening up Device Talks West in fashion.
Really cool. And then number 2 on the list, we just had news this week that Solventum is hiring out Baxter's COO Heather Knight to be their new chief commercial officer. Solventum is the former 3M Healthcare that got spun out, and man, they're just racking up the talent over here. It's kind of exciting. Being a Minnesotan, to see this company, as it gets ready, it's like going to be moving into new headquarters in Eagan, just south of the Twin Cities. But just building up this more talent, and it's really cool that Heather Knight actually was the cover of Medical Design Outsourcing's Women.
Holding up the cover.
I'm holding up the cover. I swear I wasn't keeping this magazine because there's a fly buzzing around me right now. I had this magazine. Yes, Heather. Yeah, she was on the cover because she played a big role at Baxter when Hurricane Helene just took offline like one of the largest IV products plants in the world, and she played a big role like getting them out of that, and now she's gonna be supporting Solventum with this cool company. They got Brian Hansen, the former Zimmer Biomet CEO, was their CEO over at Solventum. So just exciting to see.
Rachel Ellingson, formerly of Zimmer Biomet, and Heather Knight. If you remember correctly, Chris, Heather Knight was going to be I think she was the opening keynote at Device Talks West last year.
Wow.
And Cecilia Soriano was going to be speaking at the Women in MedTech breakfast, and both weren't able to attend because of the hurricane. So
hurricane, and it wasn't even a hurricane when it hit at that point. It was like the remnants, but just all that rain, in the mountains of all places. Like you'd think you have a plant in the mountains that's going to be safe from climate change, but not when like it dumps. I forget the amount, but it was a lot. It was something like a foot of rain or something. It was just horrible.
Yep.
It was a real disaster around there.
We had Cecilia Soriano talk about that at Device Talks Boston, and Jim followed up. Jim Hammeran, managing editor, followed up with this article.
It's really good.
In Medical Design and Outsourcing, and now Heather Knight's going to be at Solventum. And of course, we'll be. I'm not pitching conferences at this point. I'm tired of talking about conferences. May 4th, we'll be at Device Talks Minnesota. So who knows?
Who knows?
Maybe,
there we go.
Maybe she'll be there. Who knows? It could be there. Who knows? We'll see.
It's going to be great.
I'm tired of pitching conferences, Chris Newmarker. Let's move on.
Let's move on.
To number 1. This is a big one.
Number 1. Oh my gosh, yeah. Like all this news, number 1 on the list, Hologic is going to go private. They're going to get acquired by private equity firm Blackstone, private equity firms Blackstone and TPG for $18.3 billion. And it's been a really interesting trend in recent years. For years and years, since I've been covering this industry, my gosh, like over a dozen years now. And like in the whole contract manufacturing supplier space, we've seen a lot of private equity and companies going private and getting merged and all that. But now we're increasingly seeing this more with the OEMs. We're seeing them investing in stuff like Medtronic's diabetes business, or investing in Harry Schein and, working some changes over there. But this is just a full out, huge multi-billion-dollar MedTech company getting acquired by private equity and going private. So this could be when I was yesterday at MD&M Midwest in downtown Minneapolis, and kind of like everybody in that whole supplier contract manufacturing community was kind of one of our favorite places, right, Tom?
I love Minnesota. Yes,
love Minnesota. Like love talking to the whole contract manufacturer supply community. Those MD&M shows, man. They just keep on plugging along.
No conference talk. Let's move on. I'm not going to talk about my conference.
Don't talk about them. Let's not talk about them.
Yeah.
But Yeah, I mean, there was a lot of talk around there, like, whoa, look at that Hologic deal, and like wondering if a lot of the more customers we're gonna see them go private, and deals like this, like private equity coming in and acquiring device companies. So it'll be interesting to watch.
We saw Sean Hooley and another colleague. We bumped into some Blackstone folks at a cocktail party at AdvaMed. They
just had suitcases of cash right there to buy.
Exactly, yeah. They tried to roll us up right there and then. It was pretty like, just no, let go. We're not for sale.
Not for sale. How much for DeviceTalks and Mass? It's not my job. It's not my pay grade, guys. Like, how much money's in there? Like, no.
Wait a minute. You could have Sean. Sean.
You can have. I'll sell Sean to you. God, don't sell Sean, Tom. I've told you over and over again.
Anyway, my point is they're on the ground in MedTech looking for deals. So this will be an interesting one. Especially, it'll be interesting how they. I mean, these companies need to grow when they get their private equity financing. I have to think it's going to come through a lot through technology, a lot through AI. That's really driving imaging and driving diagnostics. So we'll see if Hologic, which was, as I said on LinkedIn, it was one time a prolific acquirer of, or what people were hoping would be a prolific acquirer of women's health startups, becomes now a prolific acquirer maybe of diagnostics and some of these AI companies that you and I get pitched probably every day, if not every other day. Someone's developing
a day does not go by where we don't have a story on MassDevice. I have a startup that has AI enabled medical technology. It's like, in fact, it's almost like a requirement now that if you have like a something in MedTech, that there has to be some AI enabled feature in it, so it's which I there definitely is some hype in it for sure, a lot of hype, but I also, I think there is like some real opportunity, like what AI could possibly do to kind of streamline things in healthcare and kind of get things moving along better. So I mean, it'll be interesting to watch. And Hologic, I mean, they were so much about women's health in the past, and then the pandemic hit, and they made a lot of money for a while actually on all those COVID diagnostics and everything, because I mean they had the the diagnostic machines to aid with with cancer and whatnot, and now and all kinds of other things with women's health, and they were able to like kind of pivot with that. But yeah, now they're going to go private, and I mean, there's still everything I know, everything I've heard, like, private equity, there's still like all the pressure you'd get. It's just not going to be public anymore. You won't see the public grilling on where things are going that you see with the publicly traded company.
Did they indicate whether Steve McMillan was staying on as CEO?
Yeah, I mean, they had McMillan in the news release, and there wasn't any talk of McMillan going anywhere. So, and McMillan's been a long fixture in the device industry, like especially in your neck of the woods in Massachusetts. So
sure.
So yep. So it looks like McMillan's still on board, and he's going to be taking this thing private. So.
All right. And a little bit of DeviceTalks Weekly trivia. Do you remember who from Hologic was our first OEM guest on DeviceTalks Weekly?
Was it McMillan?
Nope. It was Kevin Thornall, who's in charge of diagnostics.
Oh, that's right. Yeah.
Yep. Now he's CEO of Nevro. But yes, he was.
My gosh.
That was our first big get. Came from Hologic. So always grateful to Hologic for giving us even more street cred.
That's fantastic.
Yep.
My gosh, that was way back in 2021, right? Like when we had that.
That's a good.
It was 2020.
Let me see.
It's been a while. I think we've had a good 5 years now, man.
Well, I mean, we started March 2020.
That's right.
But I'm just trying. I think he would have been on in 20. Yeah, he was on. Yeah, now that I'm looking at it, I had to look up the date he was on, but this was actually episode 2.
My goodness.
Yeah,
5 years
March
ago.
2020, he came on. So I thought it was a little bit later into the podcast, but Kevin was on the ground floor. Our first guest was a Raj Denoy, the Wall Street analyst.
Yeah.
The next week this is boring people. Now we followed up with Kevin
We're getting all nostalgic, but yeah.
And Jan de Backer, the CEO of Fluida, who's been
there we go.
Been a return guest. So anyway,
fantastic, man. Like 5 years, like it's like time flies by when you're having fun, and
it really does.
Covering an awesome industry like this. So
all right, lots of great news this week, Chris Newmarker. We'll talk to you again next week.
Catch you around, Tom.
All right, thanks so much, Chris Newmarker. Now let's roll into our keynote conversation. Once again, I spoke with Dr. Vishwa Srivastava, President and COO of South Asia of SS Innovations International. Well, Vishwa Srivastava, welcome to the podcast.
Thanks, Tom. Happy to be here.
Before we begin to explore SS Innovations' story, I'd love to understand your story, Vishwa. How did you choose your career in medicine?
Well, it's very interesting, Tom. So before I actually became a doctor, I was an anthropologist, and
really?
Actually, and I grew up in well, first of all, I was born in Vancouver, Canada, and we emigrated to the United States when I was 4 years old. My mother's uncle, who was a surgeon. So my mom's from the Philippines. So of course, you know that the United States and the Philippines, they have very close connections when it comes to, the military and, post World War II, et cetera. So he was a surgeon in the Air Force at Kelly Air Force Base outside of San Antonio. He sponsored us to come over, and so we emigrated to the U.S. I grew up my entire childhood in Texas, between San Antonio and Midland, Odessa. And if most people don't know or haven't heard of Midland, Odessa, if you drive a car, then you're welcome, because that's where your oil comes from. And, it was a different time back then, in like the late 1980s, early 1990s. And a lot of Indian and Asian parents were immigrating to the U.S., trying to build a life for themselves. So long story short, I graduated from Midland High School. Go Dogs. And, I moved to the University of Washington in Seattle, where I started out as pre-med, just because my parents are doctors, and, usually as a first generation immigrant, that's what you do what your parents do. The reason I chose Seattle was because when I was in high school, I got really into like grunge music. And two things. I got really into grunge music, and I wanted to move as far away from my parents as I could. Right? like most college students, right?
Yeah, so that's a pretty good Venn diagram meeting in the northwest for sure. You get both of those.
Yeah, exactly. So either I could have moved to the far northeast, which was to Maine, where there's not much happening.
No.
Or I could have gone to Seattle, Washington, where, it was pretty poppin'. Unfortunately, I graduated high school in 1995. Kurt Cobain died in 1994, and grunge died with him. So I had already been accepted. I moved to UW in Seattle, and I started my journey. And I started out, as a pre-med student, taking Latin, calculus, general chemistry, biology, everything you do as a pre-med student. And I really didn't enjoy it. It didn't really gel with sort of who I was, or the proclivity, towards learning at the time. And I totally tanked my first quarter. So UW is on the quarter system.
Okay.
I totally tanked my first quarter scores on a 4.0 GPA. I got like a 0.7. Right. Yeah,
this is like Michael Jordan not making the freshman team. This is amazing.
Exactly. So then I met with my guidance counselor at UW, and she was like, "So what's going on? Like, you had, your SAT scores are really high. You have to really work to, fail this miserably." And I just told her, I was like, I don't know what I'm doing. Like, I have this big conflict of identity, of interest, etc. And then I dropped out of school. Right. Oh. And then my, a few months later, my dad calls me and he's like, "Why don't you just go travel in India by yourself? You can discover where you came from at least, my Y chromosome side." And
that's pretty cool.
I took him up on the offer, and I went, and I didn't speak the language. knew nothing about, the country aside from spending it with my family. And, I traveled by train throughout the entire country and discovered, something that I learned to love on my own. So then I went back to school. I became what's called an Indologist, so an expert in studying all things about India. Language, history, religion, politics, music, everything. And I completed my studies in that for my undergrad. And during that, duration of time, I did an overseas or abroad program in India, where I moved to one of the oldest cities of India. It's a place called Varanasi. It's in northeastern India, probably about 200 miles south of Nepal on the Ganges River. And it's one of the oldest cities, in civilization, actually. It has a written history of about 10,000 years.
Oh my gosh.
And so I moved there, and, the first time I lived away from my parents, or I lived away from the US, actually, in my life. And I swear to God, like every night, for the first month, I cried every single night because it was like, in the middle of the monsoon in India, and, totally foreign to me, struggling with the language. But eventually, week by week and month by month, it became home, like any place else, right? And I fell in love with that place because it was like a microcosmos of the entire subcontinent. Varanasi, or Banaras, colloquially called, is people go there for one of two things. They go there either for learning or burning. And when I say burning, it means cremation, like at the time of death, right? So Hindus have this very, very detailed equation and discussion and understanding of life, death, reincarnation, etc., as you might have, heard previously. But it was a really wonderful place. I learned so much about not only, the culture of India and the crossroads that it is, on the Asian subcontinent, but also with myself, being a child of, mixed heritage, between India and the Philippines, etc. So I realized that, so there's a story, and, I'm sorry, I can elaborate on it, but basically there were a group of street kids who lived in my neighborhood. And I would, always see them on the riverbanks selling, pens and postcards and peanuts and everything. And these kids were brilliant. So they're street kids. They have no formal education, but they could speak, English, Italian, Hebrew, Japanese,
Wow.
Korean, everything under the sun. And I was surprised. I was like, why don't you guys go to school? And they're like, well, we just don't want to do it. I said, all right, I'll cook up a deal with you. So in India, the school, the academic, week is like 6 days. You go half day Wednesday, half day Saturday, right? And then the rest of the school day week. I said, if you go 5 of the 6 days, then on Sunday, we'll go across the Ganges River to the beach, and we'll hang out, we'll have a picnic and, have a good time. And for 6, 7, almost 8 months, like this plan went brilliantly. And then came the time of what we call in India, it's called Holi, which is the Festival of Colors, right? Where you might have seen, pictures where people are throwing powdered dye, like on top of each other.
Yep.
So it's a beautiful thing. It symbolizes like the oncoming of like the harvest. Also, it's the idea that when you're throwing all these colors, especially in a country with the caste system, right, that at the end of the day, everyone looks the same. So you can't tell the difference between anyone else. Everyone is equal, right? Yeah, it's beautiful.
It is.
And there's this boy who was one of my favorites. His name was Ravi. Very smart, cheeky. He's like 7, 8 years old, and he was lying on the beach, and and then the children, they called me over to him. They're like, they called me uncle because I was elder to them. In Indian and Asian culture, that's normally, how it goes. And they said, come over. And I ran over there, And I looked at him, and his like fingers were blue, his toes were blue, his lips were blue. And then so I called the boatman, and then the boatman didn't come. So then I grabbed the boat, I pulled him into the boat with my friend, and we start rowing him across, to the city, which is on the other side. And then he dies in the middle of the river, and yeah. And so we got to the other side. The cops arrested all of us. My uncle from Calcutta, who's the younger brother of my father, came over immediately to get me, out of jail, saying that demanded toxicology report, this and that. So it turned out what happened is that his mother had recently become a widow, and she had 8 children, and she couldn't afford to feed the youngest one. So she poisoned him, right?
Oh my.
Yeah, on my watch, right? And, I was trying everything, CPR, all this stuff, and so then I had these nightmares. So the question was, what I decided to go into medicine, right? So I had all these nightmares, what if I, had the medical training, or what if I, could have done this? Keep in mind at this time, I'm like only 19 years old, right? So I finished the program. I escaped to Nepal, just climbing mountains. I was working as like a French translator for mountaineers, just to forget about that whole experience, but I couldn't. So then I found a program, once before I was about to graduate from University of Washington. It was called a post-baccalaureate pre-med program, and it was at Columbia University in New York. I applied, I got in, and then the next thing I knew, in July of 2001, I was living in New York City. And then, a couple of months later, September 11th happened. So that was, I moved to New York at the worst timing ever. But, looking back at it now, I think it was the best timing ever because, although I was studying science, and I did that, subsequently for the next couple of years, I really saw people come together. And being an immigrant to the United States, moving to New York and living there post 9/11 really enforced, everything I love or loved about the United States. It, this idea of America, right? That all our parents came over, your parents, my parents, etc., or grandparents, or at some point in time, of people coming together. And it really changed my perspective on, the risk all of our families took, coming over, to this land of opportunity, and, and how they made good and did, very well, in their lives. And, I know across the country, there are many examples of, whether it be medicine or, like industry or oil, gas, whatever, it doesn't matter. But it was really nice for me to be, there at that time because we were rebuilding, and you're kind of rebuilding from, like emotional ground zero, right? So after that, I decided that I wanted to pursue, rather than going directly into med school, I decided that I wanted to pursue, to follow up on this whole anthropology gig because, anthropology really makes the world a small place, right? Because ultimately it's a study of man. And it allows you to work in between, cultures and languages. And I had to learn, everything about that. Then I discovered, once I had finished my master's in anthropology, unfortunately, unless in academia, right, unless you stay indoctrinated in like, education and teaching and publication, it's really, and, ultimately searching for tenure, it's really hard to stay in that field. So my dad in 2008, he asked me, he was like, you know what I could really use? Like, I need help. So training conventional cardiac surgeons, to become minimally invasive and robotic cardiac surgeons. Because at this point, he had left Texas. He'd already joined the University of Chicago to become the director of their robotic cardiac program. And then he was recruited to go to Atlanta to St. Joseph's Hospital, which is now part of the Emory system. And he partnered up with this very famous intracardiac surgeon named Doug Murphy. So we created, collectively this organization called the International College of Robotic Surgery, wherein our whole goal was to create teaching websites, didactic modules, quizzes, exams, to teach conventional surgeons how to get to minimally invasive cardiac surgery, MICS, and robotic cardiac surgery. So I did that for the left side of the heart. Another guy did it for the right side of the heart. So left side would be coronary, bypass, and the right side would be intracardiac, so valve repair, etc. So we built those modules.
What would the system have been back then for robotic surgery? I mean,
so it was it was a Da Vinci. I mean, that was the only game in town. Yeah, so it was the Da Vinci at that time. It was the standard system
used for cardiac surgery at that time. I thought it was.
Well, I'm sure you might know this or might have forgotten this, but the Da Vinci robot initially started on cardiac surgery.
I knew that, yeah, but I
thought and their initial approvals were all for cardiac surgery.
Yeah,
and in fact, my father, Dr. Sudhir Srivastava, was very instrumental in helping them get a lot of their early approvals. And I had this actually discussion with Dr. Fred Mall. So he was, one of the founders of Intuitive Surgical. So He's our vice chairman, and he was just here this last weekend. And previously we had this discussion with him. He's like, "Why would you start on the heart? It's like you start on a gallbladder or a hernia or something simple, right?" And his logic was very simple and sound. He said, if I can do the most complex operation, and do it successfully, on this robotic platform. And, keep in mind, at the time when, they were contemplating this, it was like the mid 1990s to early 2000s.
Right.
Where it was a brave new world, it was totally unexplored opportunity and challenge. And he said, if I can if I can create a system that can operate on a heart while it's beating, then I can do everything else. Right. So yeah, initially, with Intuitive and the Da Vinci system, I think it was the SHD system at that time, or even standard system, which was actually a 3-arm system. He got all the approvals. I think he did more than totally in his career in the United States, more than 800 beating heart, totally endoscopic bypass surgeries. And then his total number was like 1,500 robotic cardiac surgeries. So, but the idea was, to build a platform where, as a teaching mechanism so that, surgeons could learn didactically, how to progress, from being conventional sternotomy cardiac surgeons to being minimally invasive surgeons. After that, he asked me to move to India with him because he needed some help reproducing the same International College of Robotic Surgery in Atlanta and translocating it to New Delhi, India in about 2010-11 timeframe, which I was happy to do. And then an event happened where he was launching some program in South Korea. And during this, procedure, the nurse put the knife right through the heart. And after, of course, during surgery, he patched it up. And after the case, he asked her, he said, well, what happened? And she said, I couldn't tell how deep. Well, first of all, there's a huge language disconnect. When he was teaching them and training them, he actually told me the story again a couple of days ago. He was like, I'm teaching him. And he's like, do you understand? And everyone's like, and then when it came to surgery, nobody knew English. So he's, at the console telling them. So basically, this nurse put this beaver blade right through the heart, and he, patched it up. And then after the case, he's like, "What happened?" And she said, "I couldn't tell how deep I was going." And he was pretty frustrated. And then he made a comment to me when he came back to India. He said, "I wish they could just see what I see." And then me and my experience with documentary videos and, through anthropology, being in the field, I said, well, they're just video signals. There has to be a way to manipulate them. So he sent me to B&H Photo with a budget in New York, which is, and if you don't know about B&H Photo, it's kind of like the Charlie and the Chocolate Factory for audiovisual, nerds. Like all production, all, people, like they all go there. It's right by Penn Station. I think it's on like 37th between 6th and 7th Avenue. And I spent 2 weeks there, with these guys, buying them lunch and, pizza and deli sandwiches and stuff, just on a whiteboard trying to come up with a proof of concept. So finally, after 2 weeks, we came up with a POC, and I ended up having to like smuggle 5, very expensive, electronic components back to India, just like daisy chain together, just to give 3D vision from the Da Vinci system onto a consumer grade 3D monitor that I could buy at like Best Buy, like Samsung, LG, whatever. I was able to do it, and then we hired a couple engineers, software and mechanical, to be able to consolidate, skeletonize all the essential functions from each of these individual components and consolidate them into a single box, like a unit, which at the time we called Omni. Then, and it worked, and it took us about 1.5 years to do that. And then in 2013, there's nothing left for me to do in India. I already made this thing for my dad. I came back to the US, I registered that device with the FDA, and I was driving around like a traveling salesman. I moved to Miami, teaching yoga and being a traveling salesman. And I was driving around to all these academic, surgical programs, pitching my invention or solution, on the utilizing as an interface for the Da Vinci platform, so that everyone in the operating room could see everything in 3D, right? And have the same vision as the surgeon whose head was buried in the console, right? And I did a clinical trial in the US and China and India, and I got my registration approval. And then one day in like 2013, 14, I was driving from Miami to Chicago, because we used to live in Chicago, and my dad was visiting me in Miami, and I was going to conduct this trial at the University of Chicago. And we got caught in a blizzard. And my dad, I looked at him and I said, this is my life. I'm like a traveling salesman. I might as well be selling like vacuum cleaners or something, like in the 50s. And he's like, well, what do you want to do? And I looked at him and I said, well, what would you think if I decided to, go back to med school and become a doctor? And he said, I think you should go for it. So we were literally at this truck stop, or, this service center, where they have like the McDonald's and, the Arby's and all those things. And I started searching online, and this is like, I didn't even have an iPhone. This is like back in the days of like the BlackBerry. And searching online, I found a program, applied, I got in. And then sure enough, about 6 months later, I started medical school. And then I went through that whole journey, and then I ended up finishing in Chicago. My greatest area of interest and training was in surgery, most general surgery. Although, I've always been very close to cardiac surgery, but my passion was in like trauma surgery. I did some work at Cook County Hospital. I had amazing teachers, etc. And then the pandemic came. So I didn't have any like illustrious surgical career because I came into it much later in the game. Then the pandemic came. My dad, reached out to me. He's like, hey, listen, I could really use your help. And he said, I don't know what you have to offer, but I know you have something to offer, because robotic surgery, the developing world, India, patients, medicine. So let's throw a bunch of stuff against the wall and see what sticks. And, I was pretty tired at that time of the pandemic and, the polarization of the country, that we were living in at that time. So I was like, you know what, let's do it. And my wife and I, we moved to India in 2020, and we built, and I've been through like all the iterations of our mantra system. And I've been also through the different iterations of our economic stability. Like there were times early on in the middle of the pandemic where, we ran out of money. entire senior engineering team. They offered, they're like, just take half of our salaries or don't pay us, just so that we can keep the lights on and keep the doors open. And then my father was like, no. I mean, I appreciate your sentiment, but we'll just do a deferred payment and we'll pay you back, whenever we get funding. As you know, projects of this sort are not cheap, right?
So what drove why was SS Innovation seen as something that needed to be started? What hole were you trying to fill?
Yeah, so the gap basically we're trying to fill was, my father, being one of the early, pioneers and poster childs for robotic cardiac surgery. He always made it his mission to see, with all due respect to other surgical specialties, they all had laparoscopic endoscopic options, right? Like minimally invasive options. When it came to cardiac surgery, you have either this and you have a handful of people who can do this. But that's, like 2 to 5% maybe.
For those in the podcast, you drew your finger across your chest and then across a portion of your chest.
So for everyone on the podcast, so this is what we call a median sternotomy, where they basically saw through your breastbone in order to gain access to your thoracic cavity or your chest cavity. And then there are some surgeons who, got away from this median sternotomy and they wanted to focus on something like through here, which is called an anterior thoracotomy, where they go between the ribs and then they spread the ribs and they're able to open up and gain exposure towards the heart. And traditionally in surgery, all other specialties from the chest down, they all have laparoscopic, meaning keyhole surgery through, hand-controlled, instrumentation, which extend, the movements of, pinching and grasping and suturing, etc. But there's no such similar option for cardiac surgery. So he, seeing the benefits of it, became very passionate about, his patients would go home in 1 to 2 days, following, major heart surgery. And it was unheard of. I mean, most people who undergo conventional heart surgery, which are still like 98% of the population today, it takes them, 3 to 6 months to recover fully, where his patients would go home in like 1 to 2 days and they'd be back to work in like a week to 10 days. Yeah. So he saw the benefits and he wanted to really drive it forward and the people who could do what he does did and does today. I mean, I can count on 2 hands. There's, see, the thing is with cardiac surgery, it's a very complex surgery. That procedure, the beating heart bypass, you need a stabilizer to stabilize the heart while you're trying to suture, for the bypass. It's extremely technically, challenging. And with all due respect to other specialties, cardiac surgery is the one specialty where you can kill a patient on the table immediately. And you can easily introduce a myocardial infarction or a heart attack onto the patient, and then, you can kill them. So the adoption rate, as you can imagine, was very low. But there are people who were able to do it. It is reproducible. And I think, people are hungry for it today. So I think it's, SSI in our Munther system being one of the few systems that's able to, or that are even approaching, solutions towards robotic cardiac surgery. I think we're developing ways in training and sustainability to be able to make these services available within the cardiac surgical realm. So basically, getting back into how I got into this, I've been through the company, started here, now I moved back to India. My wife, she's from Massachusetts, like you. She's of Dutch heritage. She's an artist. She was stoked to move to India because being an artist, there's an enormous wealth of artistic tradition, in this, country and culture. So she was really happy to move here. And since then, we went through Munther 1, which we realized wasn't going to work. Munther 2, which we've done the majority of our cases, is our flagship system. Even doing cardiac surgeries, on that system. Major difference between Munther 3 and Munther 2 is that the arms are about 40% slimmer than its previous, generation, and capable of telesurgery, which are 2 big things, right?
So at the time you started the company, I mean, Medtronic was in the midst of trying to develop its system. Johnson & Johnson was going through its processes. I mean, it's taken so many companies so long to put something together. How do you look past that as a company and say we're gonna do it faster and deliver on that? Was there any hesitation at all that these larger companies are trying and not getting there yet, and we don't have that as long a runway as they do? And how were you able to develop what you have so quickly?
So there's two ways of looking at it, right? Like, one is when you're poor, you have to work fast, right? As you know, raising money for such projects is not easy. And, you always try to raise enough money to get to the next stage, the next level, next milestone, so that, when you raise more capital, then you can hire different level of engineers, different level of salespeople, different level of, support staff, etc. These larger companies, I mean, see, for the companies that you just mentioned previously, they have 1,000 other products, right? And if their robotics project fails, then it's just a tax write-off. Whereas us, very much like Intuitive, we're a very single-focused company. And we put all of our investment and time and effort into creating our main goal was to create a stable, multi-arm soft tissue surgical robotic platform that should work. And the only three things that people care about in robotic surgery is the vision good? Are the instruments doing what I want them to do? And will the procedure, proceed uninterrupted? That means you shouldn't have any glitches or faults or stuff, technical issues that would prevent the surgeon from having an uninterrupted, experience. And these are the main three things we focused on. In the beginning, like any other company or technology, there are issues, and we work through them. That's why we have clinical advisors and experts. And as you know, everything works perfectly in the lab. But once the tires hit the road, and then that's when you've learn your limitations. Part of the thing that helped us work really fast is that in India, we have a really wonderful team, young, bright engineers. I think our average age of our engineers is probably like 26, 27 years old. None of them had robotic experience. They all come from, like automotive industry, some from automation, some from industrial robotics. A lot of people like from the assembly people, like diploma level type people. But we hire, people who, as long as they're passionate, as long as they want to do good work. And I can tell you today, right now, the team that we built over the last, 7 to 8 years, they know more about robotics than the professors teaching about it in like the best institutions in the country. And, just hands-on learning approach and self-study. And for me, actually, funny story. So before I took the gig and moved here in 2020, my father, he wanted me to be in leadership position. And, me, coming, from medicine and surgery as this arrogant doctor, I was just like, oh, it's an engineering project. It's science. Like, it'll be way easier than medicine. So when my wife and I were on our honeymoon, we were in Washington State before we left the U.S. He asked me, he encouraged me, he's like, why don't you attend one of our technical meetings, round table meetings where the entire technical team leaders, they all sit together. And so I chimed in one day and, I was like, said hi to the team I was supposed to, not only be working with, but lead. And I started listening to them talk about, their R&D and developments and, design, documents and, like requirements and requirement documents, etc. So probably about 5 minutes into their discussion, I start hearing all these words I never heard before. And then I asked my wife, Monica, I was like, Monica, give me a piece of paper and a pen. So she did. And I started writing down all these words I've never heard before, right? Like ever. And I'm pretty, I have a pretty firm grasp of the English language, but never heard these words before. And then, halfway through their meeting, I was just like, oh my God, like, not only, I'm leaving everything I know as a doctor, but I've been recruited to help lead this engineering project, which I know nothing about. And I'm the freaking president and chief operating officer of this project, right? Thank God when I got to India, the engineers were very gracious and they took the time to, teach me everything I needed to know. And they referred books. And then I did a lot of self-study on like mechatronics engineering, mechanical engineering, software, et cetera. And so now I can at least attend meetings and I don't need a translator to understand what they're saying.
So what was the view or the objective of SS Innovations when it was started? Was it to develop, and you've grown into an international company, you're selling in multiple markets, you're pursuing approval in the US. Was that always the goal? Were you just going to be servicing the India market, which I'm sure is substantial? What was the objective when you set out to start the company?
So that's a great question, and I think I need to circle back because I think I missed out of what kind of got us started in the first place. So when my dad came to launch programs here in 2010-11 timeframe, there was this lady who would come in. She had a condition that was called atrial septal defect, which is a congenital disorder where you have a small hole between the two upper chambers of the heart, between the left and right atrium. And normally people only experience, symptoms later in life, right? The brother had brought her in saying that if she has a huge sternotomy scar, which everyone now on the podcast knows what it is, that, the chances of her getting married culturally would be, slim to none.
Oh, wow.
And my father offered to do it was a perfect candidate for a robotic approach. They would just make 3 tiny incisions between the ribs on the right side, accessing the defect. And they didn't have money. He offered to waive his fee and do it for free. Hospital still wanted to charge 400,000 rupees, which is, like today, $6,000, which is still way cheaper than, doing it, in the US. But the hospital forced them to pay, and he never heard from them. So that was the moment he decided that, we must do something to create an affordable system because this is such a wonderful technology. And people, on a side note, and I gave an interview with Liz Moyles not too long back. She asked me about Intuitive. We at SSI, we have nothing but admiration and, are very complimentary towards Intuitive because why? And Dr. Fred Moll, because they showed us a new path. They showed us a new paradigm on how to approach, treatment, of very sick patients in the most till date, minimally invasive way. And, when I look at other companies, whether it's Intuitive or Medtronic, J&J, the companies that you mentioned, and others, there are 40 companies globally right now that are pursuing soft tissue surgical robotics. I gave this industry talk most recently at the SRS meeting in Strasbourg. And I said, and I told them, the audience, and they're all sitting there, I said, it's so wonderful that there's so many other robotic companies here. Why? Because, and don't take this in an arrogant way whatsoever, I don't look at you all as competition at all. I look at you guys as my colleagues. Why? Because you're all developing individual robotic systems in your parts of the world, your demographic areas that are helping other patients. They're helping patients avail of this wonderful technology of the least invasive, surgical techniques to get patients back on their feet and restored, to their daily living. So, and then I had mentioned that they're not my biggest competition. My biggest competition are laparoscopic towers, but that's a totally different conversation. Right? So what got us into this is that we wanted to develop an affordable system because if you look at the market share today of robotic systems, there are approximately 10,000 systems in the world today. About 90% of them are between North America, Europe, and Japan. Of course, that's skewed to the left if North America is on the left side, because there's about 7,000 systems over there. So what that means is that globally, and then of course Japan as a single country, I think has the highest per capita number of robotic systems for any single country. But what that means is that 7 billion people have only 10% access, to surgical robotics. So, when looking at the market share, I think market share is the wrong word because we're not trying to share the market. Our goal at SS Innovations is we want to make the the market larger by addressing those other 7 billion people who don't have access. And the only 3 ways to do it are this. The biggest hurdles, and barriers to entry historically have always been the capital cost of the system, which in the past has been, in the US, it might be justifiable, but in the rest of the world, it's beyond their means. The running cost of the system, which is the per procedure cost, which is ultimately translated across to the patient. So, $1,000, $2,000, in the US to the hospital, and keep in mind that every healthcare system, hospital system, network, etc., there's a huge disparity and difference of how they're run worldwide, right? The US is very different than the NHS, which is very different than Sweden, which is very different than India or Australia, etc., right? But ultimately, there's a landing cost to the patient. So that has to be within reach. And then there's the maintenance costs of the system, the CMCs, the comprehensive maintenance costs. And ultimately, either that's translated across to the patient or it goes to the hospital. So if you have something that's very expensive, and it doesn't matter, if it's our historical precedent or the new companies coming up trying to follow that model, they're not solving the problem that, that got us into the problem, we are, to begin with. And for us, the problem that I'm addressing is inaccessibility to advanced surgical robotic care. And to me, that's, the only limiting factor is the cost, right? Training, and then creating sustainable and independent programs in light of the limitations of the previous 2 issues, right? And this is, a big challenge, in the US, because of the reimbursement, et cetera, level of training. They've also incorporated surgical robotic training into residency programs where people come out of residency as trained, robotic surgeons. The rest of the world is still catching up. Why? Because, they're lucky if they can afford a robot in the first place. So at SSI, when we developed our system, so first of all, there's this big misconception that just because you're making a system cost effective, people use the word cheap. I hate that word, but it's cost effective, meaning that we wanted to make it affordable, accessible. We didn't want to compromise on quality and of the components that we're using, the safety of the system. And, till date, we've done now in less than 2.5 years, more than 5,000 surgeries, placed more than 100 systems, mostly in India, but still globally. And till date, we've had zero device-related adverse events, mortalities, or major complications, device-related. There have been conversions due to anatomical issues, etc., or the skill levels of the surgeon who weren't comfortable, but due to the device, we're triple zeros for mortality, injury, or complications. We wanted to be able to make a system that the average, like an average surgeon or a very skilled surgeon could use. In keeping in mind that like a lot of our surgeons who utilize our systems, who really helped us through our evolution, our R&D stage, they're all previous, robotic surgeons, on the, the historical platform. And we kind of, raised the question, like, if you could develop a system, on your bucket list, what would you want to include? And they were all very, vocal. We listened to them. We, incorporated a lot of their ideas. And at the same time, we still wanted to make the system, work in such a way that, it would really lessen the learning curve in adoption. See, because at the end of the day, right, a robotic system is purely an instrument in the hands of a surgeon. It's like, we're not teaching surgery. We're teaching people how to use our system to do something that they already know in a very safe and an efficacious manner. So that was really our philosophy, and we're sticking to it. We're sticking to addressing the needs of what I call the forgotten world, the 7 billion people left behind. I'm not trying to take any market share. If anything, I'm trying to make, I'm not, trying to take any piece of the pie from anyone else. I just want to make the pie bigger. And if I can do that, if other people can do that, then we're truly, falling back into like why we got into medicine in the first place, why we got into surgery in the first place, why we got into healing and being patient advocates in the first place, to try to make the world a better, healthier place. And I think there's a fine line or, a way to do that while still, being successful, remaining profitable, effectuating positive change, and most importantly, helping as many people as you can, while you have the time.
I always feel that in the U.S., and that's the area I focus on mostly, the adoption of surgical robotics was something that, or the push didn't come necessarily from the customers, from the clinicians early on. It came from the MedTech industry sort of offering the solution. And there's obviously a mix of that. There were some surgeons who were early adopters, but I didn't feel like hospitals were clamoring for surgical robotic systems. I think that's changed over the last couple of years. What are you seeing OUS across the world? Is this something that hospitals are clamoring for? They want a system like Mantra that they want. They're pulling you into their facilities as opposed to, I think, the push dynamic that I'd seen over the last couple of decades.
See, in the U.S., let me just address that first point. See, as you know, in healthcare system, right? I mean, everything comes down to money and volumes, right? And that is tied with the evolution of surgical care. So you have open surgery, right, which we all learn, and at the end of the day, that is ultimately way more expensive, to the hospital, than robotic surgery or even laparoscopic surgery. Why? Because the patient, has a maximally invasive procedure. They stay in the ICU longer. ICU in all hospitals is the most expensive real estate in any institution, a healthcare institution that requires the most amount of resources, to get the patient from post-op, into recovery. And then they have prolonged stays in the hospital, right? So now, one, you have very expensive bills. Also, that same bed is used by the same patient for a very long time. So now, even in developed economies, you have less availability of beds due to prolonged hospital stay.
Mm-hmm.
I'm talking 20, 30 years ago, right? Before, or right around the time of the advent of LAP. And open surgery was great for the surgeons, horrible for the patients, right? Then you have LAP, which is now shorter hospital stays, keyhole surgery. Patients go home much faster, lesser chance of infection due to smaller incisions. And it was great for the patients, but really bad for the surgeons. Why? Because in the LAP, like all the movements are, counterintuitive. Like if I want to go down, I have to go up. If I want to go right, I have to go left. Suturing is a pain. But people, they got through it. And, India actually has the largest number globally of very gifted laparoscopic surgeons. Then comes, Zeus and Dr. Mall and the advent of robotic surgery, which now they're trying to fill the gap. So how to do laparoscopic endoscopic surgery, but having, the benefits of open surgery. So then, of course, is robotic surgery. So you have wristed instruments, 3D vision. It's like you're doing an open surgery, but you're on the inside of the patient. And it was wonderful for everyone. But in the beginning, right, the adoption and especially, it's the natural evolution of science, right? Like there'll be people in the beginning who are opposed to change. And even when laparoscopy came around in like the 80s, people were shouting like heresy and, it was like a witch trial and this and that, you're going to kill everyone, if you do it this way. And what do you mean you can't feel the tissue, and then with robotic surgery, it was even worse because now you're away from the patient, right? At least at LAP, you're next to the patient. But then it's become accepted, and it took time, but there was a huge ignorance, even amongst educated people, that the surgeon is actually doing the surgery, right? In the United States, this is a big thing. And then you have the naysayers. So the people who were shooting down, my dad used to tell me about this, like the biggest, people who would shoot down robotic surgery are the ones who were unwilling to try it or who just couldn't do it. Right. And he started his career in robotics when he was like 50 years old, like older than me. I'm 48. And he just got his feet wet, like when he was 2 years older than me. And he's still operating today and he's 77 years old, on the system that he built. So that's pretty cool. But how it's happening OUS. So now it's accepted in the US. But even if you look in the US, Tom, it's like there's still 35% penetration, amongst the 6,000-7,000 systems that are in the US today. That only, occupies 35% of the country, which means that where I grew up in small town of like Midland, Odessa in West Texas, patients still have to travel to like the big cities like Dallas or Austin or Houston, just to avail of these advanced treatments. And imagine if that's me coming from a town of 100 and 150,000 people, the majority of the country is like that. So what we're targeting, in the US, God willing, once we get our US FDA, is that I'm going to target, I'll target the cardiac centers because that's one of our, USPs. We're the only ones that's really touching the entire spectrum of cardiac, because we have all the instrumentation required to do it. But I'm also going to target, the ambulatory surgical centers. Joe Mullings and I, we've had this discussion where there's a huge opportunity in that realm with even with our 3-arm system. You could easily place it. See, in robotic surgery, even with 3 arms, you can easily perform 70 to 80% of most surgical procedures across most areas of the body. In the abdomen and pelvis, easily 70 to 80%. Heart, lungs, maybe less. But most common procedures you can do, especially in ambulatory centers, community hospitals. So patients don't have to get referred to like the larger university hospital in Dallas or Houston. And there's a huge socioeconomic impact that occurs though. It's not only the patient who has to travel, family has to travel, staying in hotels, ordering on, Uber Eats or DoorDash or whatever they have to do to get their food. And then everyone has to take time off of work in order to do that. If there's a way that I can offer the same level of care, at their doorstep, then that's something I'm very, happy to explore. And then the other thing would be the cost, right? As you well know, insurance companies hate paying, more for less.
Yep.
Right. So if they're willing to pay less for less, then I think that might be a winning combination. And robotics in the US is, coverage, at least, in private insurance is easily and, well acknowledged and accepted. So I think, that it'll be a game changer. And I know other companies are already, taking advantage. I know CMR's there and Distal Motion's there, and they're, they're chipping away and doing their work, which I think is great, because more people get help. Outside of the US, part of the reason why we wanted to start in India, aside from our company being here, our team being here, is that India, with a population, so it's a country, for your, listeners who don't know, we're about a fourth the size of the United States with 4 times the population. So imagine that, right? Yeah. So, and it's a very, as you can imagine, a very price-sensitive healthcare market. And so we felt that, the way I describe it is like if I can drive in India, I can drive anywhere in the world, right? And same way with healthcare, but if we can drive our vision, drive our mission, drive our, project and system here in India, which is a very, challenging place, to do business when it comes to offsetting healthcare and price negotiation and implementation and, sustainability. We were able to, be successful here in India. And once once we got past this whole watch and wait, like this new kid on the block, new robotic system, yeah, they're probably going to fail. Once we got out of that, window, that gray area, then I started getting calls from other parts of the world, like in South America and Africa, Southeast Asia, Eastern Europe, and Western Europe, because as there's there are also struggling parts of Western Europe. I get calls from Portugal, from Greece, from Italy, like many places, Scandinavia, because they have their social healthcare system. And why spend more for using taxpayers' money for robotic surgery when you could treat 3 times, 4 times as many patients on my system? So the world is very excited, I believe, based on the feedback I've heard from distributors and surgeons about, what we're doing. But I think they're more excited about, we've been very good about detailing and outlining and communicating our vision as to not only why we're doing what we're doing, but the core ethos of why we believe what we're doing, is good for the people. And ultimately, at the end of the day, people have choices. I mean, some surgeons like, Intuitive, some surgeons like CMR, Medtronic, J&J, they might like it if we ever saw what it looks like, So one of the funniest things from SRS was they were giving their talk, and I'm sure you know who was giving the talk. And at the end of the talk, Dr. Vip Patel was like, not even one picture, and, because we've all been, on the edge of our seat, just waiting to see what happens with them. But see, at the end of the day, I truly mean what I said, that I think it's great that there's so many other robotic companies. It's just like, it's like driving a car. Some people prefer driving sports cars. I drive a truck, a pickup truck, and everyone, has a different way of doing things. But ultimately, the goal should remain the same, that we help as many patients as we can. I think there's enough food for everyone even though, everyone in surgical robotics, they're hungry for more business, etc. I think we should take a step back and, collectively and remember why we got into this in the first place, right? And when we're able to do that, I think that also helps, clear a lot of the clutter in our brains and the tunnel vision, and it really allows us to contribute. And one, message I'll say, if there's, any people watching from the other companies, is that, I really, when you enjoy your work and you enjoy, the colleagues that you work with, I think you can effectuate more positive change. And unfortunately, people get sucked into this entirely capitalist mindset where you feel that, someone is out to take what's mine, and I think we should not focus on, taking what's mine, but focusing on collectively giving, what's ours, from the work that we do. And I think if one is able to direct their attitude, their mental shift and awareness, based on looking at things from that point of view, and I could be wrong, but I think, it makes work more enjoyable. You feel like you're doing actually something good. And ultimately, your quarterly earnings, your milestones, all that stuff will come automatically, I feel, because, you're doing good work. And at the end of the day, I'm still a softie, and I think the universe is looking out for you.
You're still driving a pickup truck. I guess you can take the boy out of Texas, but you can't Texas out of the boy. Final area I just wanted to cover, just the telesurgery element. You folks have been really pushing this forward, and there's certainly discussions, whether this is, again, as sort of technology that's the engine of the train, pulling it forward. Do we really need this right now? I know I had a conversation with Brian Miller about their intuitive statement that we really need to, this needs to be physician driven. From your perspective, again, you've put this front and center. How big of a part of your future in surgical robotics future is telesurgery? And are you seeing things differently? Are you seeing physicians who are like, we need this now, like this needs to happen now? Are you feeling that demand and that pressure?
Yeah, so Tom, that's a great question. And see, currently globally today, there's only two people doing, telerobotic surgery on patients. It's us and the companies from China. Right. And this is one thing I learned from, the SRS meeting, especially the only people who are actually operating on patients were SSI or Microport or Kangdo or Edge. I think they can also do it, from Shenzhen. And everyone's operating on, animal models or inanimate models, etc. See, in the US, the other companies from the US, like they have the full capability to do telesurgery. Unfortunately, they don't have the regulatory environment that allows them to operate freely within that. And even if that regulatory environment became very friendly, then, from a medical licensing point of view, you still have that same, cross-state, licensing issue. So that if I have my medical license in Illinois, I can't operate in New York or California.
That was an issue even with teleconsulting during the pandemic. If your doctor's in New Hampshire, but I live across the border in Massachusetts, it can become an issue.
Yeah.
So
I think where it might work in the U.S., at least, let me focus on U.S. and I'll focus on OUS. In the U.S., I think the only way that it can work in the short term or even the midterm would be that, you focus on establishing, allowed either advanced telehealthcare, so teleproctoring and telesurgery within the state. So take, for example, like an organization like MassChat, right? They have like 13, 14 hospitals within Massachusetts. I think one's in New Hampshire. So at least if they operate in the 13 out of the 14 hospitals in Mass, then they can utilize it, for telesurgery. But now the question remains is that, okay, telesurgery, in the beginning, there was a lot of hype, but it works. And the only thing you're proving is that your internet works and that your system is stable, right? So now the question remains is what do you want to do with it, right? So yes, and the way that I see it, there are several solutions. One, you can utilize how the robot was originally created for, advanced surgical procedure, either in space or the battlefield. Obviously, battlefield is way easier than space, although the University of Nebraska was able to demonstrate, I think last year, which was brilliant. And so, of course, there's an Army application to that, being able to, have a robot in the field. But see, even in telesurgery, you always have to have a physical team on site on the receiving end in order to take over. Let's say, for example, if the internet signal drops out, or if there's a horrible complication and they have to convert to either a laparoscopic or open procedure. So there has to be a team there. Second best case scenario that I feel is that you utilize telesurgery for teaching and training to create sustainable surgical robotic programs. So just as people train when they're in their residency, right? There's always an attending in the operating room. And the attending, it might be they're guiding the student. So someone who's guiding a younger or a student surgeon, they're serving as a proctor, right? The goal of the proctor is not to do the surgery, but to bring the student to maturity, right? And so now let's say if I'm doing a Whipple or something, and I get stuck on a difficult part, either due to, anatomical challenges or complex of the patient, complexities of the surgery, or limitations of my own skill set, then rather than giving up and abandoning the case, right, and converting to an open, easier procedure, which ultimately would be worse for the patient, then someone with more experience utilizing telesurgery, who was previously teleproctoring me, guiding me, the same way that an attending in residency would train me, then they could take over telesurgically, get me through that step so that, I can then finish the procedure, being confident that someone is not only looking over my shoulder, but they also have my back. And so at SSI, we are looking at utilizing telesurgery, and this is one of the main utilizations of that platform is from a teaching and training point of view to help create and build self-sustainable surgical robotic programs. And in the beginning, the student might do 50%, then the next case they might do 75%, and the next case they might do 100%. But at least we're offering them, the training wheels and what they need, to do. Because see, proctoring in today's day and age, whether you're in the United States or India or China, it doesn't matter. Like you have to take 2 days out of your life. You got to fly, you have no idea about the surgeon's skill set, no idea about the complexity of the patient, that you're about to operate on. And, it's completely inefficient. So we might as well utilize technology, in 2025, where we are today. The technology is available. It's there. It's safe. Teleproctoring is safe. Telesurgery is safe. We have an average latency of about 30 to 40 milliseconds. And the other cool thing that most people might not know is that in the beginning, when we were exploring telesurgery, that I thought, intellectually that we'd need like gigs, per second of speed. And we were pleasantly surprised, and God bless our software engineers at SSI, but they were able to write an algorithm where they were using like per telesurgery less than 25 megabytes per second.
Wow.
Of data, right? Yeah, it's amazing. To accomplish like less than, 40, 45, sometimes 50 milliseconds. But you think about it, like 40 to 50 milliseconds is like less than 1/20th of a second. And all the surgeons who've used our system, during telesurgery, they feel like it's real time. I know Microport, they've done hundreds of telesurgeries, and, that's great for them. Till date, we've done now more than 35 robotic telesurgeries. We just did our 36th one today. We did a robotic hysterectomy sitting in our office. So and now what's one thing that's really cool. So now in India, this is actually I'd love to share this. So there's Hospital A that specializes in general surgery and gynecology. And then Hospital B in the 3,000 kilometers away in India that focuses only on urology. So now what these two hospitals are doing, they're becoming friends, they're becoming colleagues. So anytime there's a urology case in Hospital A, the head surgeon in Hospital B will operate through telesurgery.
Wow.
And anytime there's a general surgery or gynae surgery in Hospital B, the surgeons from Hospital A can then operate. And then this is how they want to try to do a paradigm shift, in healthcare. Just like having different operating rooms but thousands of, miles away.
Well, that's it
Pretty
right there.
cool.
I mean, that's the clinical need. That's the market. That's the market demand. So yeah, you can certainly see.
So to answer your question in light of efficiency, I think this is what people are pushing. So it's once they get over the hype of telesurgery, then you have to ponder on the application. And when you ponder on the application, I think that opens up a whole host of opportunities of creativity, right? In order to explore now the limitations of travel, of being able to expand the expertise. When I was in SRS, I saw something was beautiful. I saw Vip Patel. He was sitting in Orlando and he had 3 surgeries happening. I think there was one in Kazakhstan, one in Angola, and one in Beijing, right? And he had people doing work and he just kind of like push buttons and he would just go to one operating room and he would do some work and then he'd push another button. He'd be in Kazakhstan, like filling in, and then he would connect, Beijing with Kazakhstan. And, it was just like this amazing, the possibilities are endless. And I think we're at a very nascent stage of, when it comes to connectivity and utilization and also, application of being able to, extend the expertise of one surgeon to multiple sites, right? Teaching and training. I mean, I think, there's going to be, and I foresee in the next, it took us, the last couple years to develop up to the stage. Microport and other, companies from China have been silently, doing, just chipping away, doing their telesurgeries. So have we. Now the rest of the world is getting interested. And, they're probably in the honeymoon stage where we were like a year ago. But then eventually we need to figure out and come together of, what are the guidelines? What do we need to do to make this actually beneficial for most people beyond just the commercial aspect? Mm-hmm. Because now you can extend the expertise of people globally. And I think the possibilities are endless. So I think it's not the patients who might demand for it. It's the patients might demand for the expertise of surgeons who might not be in their network. And I think that is something that will be very interesting to look at moving forward.
Really exciting stuff. All right, Vishwa, thank you for sharing your story and the story of SS Innovations. We appreciate you joining us on the podcast.
Thank you, Tom. And I hope I answered all your questions. I feel like I jumped back into our last talk where I did all the talking and you hardly got a word in edgewise, but I really appreciate your questions.
I know my place. They're here to hear you and not me, so I think it'll all work out.
I'm here to hear you. How about next time I'm in Boston? Like we'll go out for a beer and we'll have an equally balanced conversation.
That sounds great. We can do some driving. You can tell me how it compares to India.
Oh my God, sounds great.
All right, well, that is a wrap. Thanks so much for joining us on this episode of Device Talks Weekly. Once again, I hope you'll join us on Device Talks Tuesdays for our surgical robotics conversation, sponsored by Spectrum Plastics Group, which is a DuPont business. You can go to devicetalks.com to register for that. It's happening live Tuesday at 4 p.m., or you can watch it when it's most convenient to you on demand. So register right away. I don't have any conferences to talk about. We'll be back in, of course, 2026 with DeviceTalks Minnesota and DeviceTalks Boston. Both are taking place in May, but let's just give the conference stuff a rest. And thank you for listening to this podcast episode. Please subscribe to the Device Talks Podcast Network so you don't miss a future episode. And make sure you share this podcast episode on LinkedIn. And please, while you're on LinkedIn, connect with me. Connect with Chris Newmarker, connect with Kayleen Brown, our managing editor, And please follow Device Talks. We're over 10,000 followers now. We love having your support. We'd love to have you as part of Device Talks' discussions on LinkedIn. So make sure you do connect. All right, folks. Thanks again for listening to this episode of the Device Talks Weekly Podcast.